everyone, and welcome to the Wealth of Health podcast. My name is Ahmed, and with me, as always, is Dr. Paul Jenkins, consultant physician and endocrinologist. For most people on the internet, the debate about statins and cholesterol is settled. It's debunked. You've been lied to for decades. Cholesterol is not bad. Statins are the devil. You can start your carnivore diet tomorrow and eat 3 steaks every day and 20 eggs and rashes of bacon, and you'll be fine, because it is all a scam. The pharmaceutical companies have lied to you and they're making millions, and doctors are definitely benefiting from prescribing statins. But move across the aisle to the medical world and you realize that doctors don't just prescribe it, they believe in it. They actually take it themselves. They will tell you that cholesterol is definitely a risk factor for coronary heart disease, and you should monitor your intake of saturated fats and meats. But what we'll try to do today is look at the middle, where everything lives and no one wants to be, because it doesn't give you clicks and it doesn't make you famous. But what you'll definitely find in the middle is a lot of common sense. Today, we're talking about cholesterol and statins. Paul, what is cholesterol?
Well, cholesterol is a form of fat in the body, which is an essential component of our body. We need cholesterol for cells, for the nerve fibers, for parts of the cell membranes. Yes. So, if you accept cholesterol is essential, but it is also, and I'm afraid I'm going on the medical side on this one, too high a cholesterol is, in my view, clearly associated with a risk of developing coronary heart disease.
Let's define coronary heart disease and then move on to the origins and why it is thought that cholesterol is a risk factor. So what is coronary heart disease?
Well, coronary heart disease, in essence, and to some extent this is also, we call it now, slightly wider range cardiovascular disease. It's disease of the major blood vessels, whether that's in your heart or the brain or the arteries supplying the brain, or peripheral, your limbs. But it is the furring up within those arteries. Yes. A slight analogy is akin to the furring up of your kettle. Yes. So with time, you get bits of fatty, so-called plaques, areas of furring up within the wall of the artery, that with time can inroad onto the artery, to the middle of the artery, and then eventually obstruct the flow of blood. So that can give rise to insufficient blood flow to the organs, and in the heart that can give the symptoms of the chest pain, the angina, intermittent pain, especially when you're exercising and your heart needs more blood flow. You get angina. And then, the real issue is that those areas of furring up can rupture, burst. And when they burst, you get a blood clot forming on them, and then that occludes the flow of blood. And that's what causes a heart attack.
So how long does it take for this plaque to build up in the arteries? And is it all the same, or are there different types?
It takes years. It's a long time from the very earliest signs of plaque development to, or can take many, many years to resulting in either angina, obstruction to flow of blood, or heart attack. Yes. Let's be clear as to the degree of importance of this. Yes, because cardiovascular disease is the most common cause of death in the UK or in the developed world. It's around a quarter of all deaths are due to cardiovascular disease.
Is that in men and women?
Yeah. But in women, and many people aren't aware of this, cardiovascular disease kills, twice as many women as breast cancer.
Wow.
So it's a much, much more common, because people traditionally think, and to some extent doctors, this is a disease really of men. But in women, especially after the menopause, it's a major factor.
So that plaque gets built up in the arteries over years, but how frequent or how quickly it builds up, I guess, depends on lifestyle and genetics and all that.
Yeah, I think it's important here, and we're coming back to it. Cholesterol is just one risk factor. Yes, we've said before, the chance of whether you suffer a heart attack is probably like many diseases, is a third. Yes, so it's a third genetic. If you have a strong family history of heart disease, you are at much increased risk of getting it yourself. Yes, a third is just chance, and a third is lifestyle and other risk factors. Yes, and of those risk factors, it's smoking, it's high blood pressure, it's being obese, sedentary, not doing any exercise, it's diabetes, and then it's cholesterol. So cholesterol, you can see, is not, the be all or end all. And this
Okay.
is where I would agree with your first statement about the pharmaceutical companies. Yes, they might try and get you to get one in general to believe that high cholesterol is a disease. This, in my view, it is not a disease. It's just one of several risk factors for the development of coronary heart disease. And that's what we're trying to address and prevent.
Okay. So there is a crossover between the medical world and the internet.
Yes. Yeah.
There are
Yeah.
points of agreement.
Yeah.
Okay. So if someone's arteries are blocked up by plaque and it builds up over the years, I mean, first of all, how do they know that plaque is building up in their arteries? And also, when should there be a step to stop it from progressing or to treat it if it progressed too far?
Yes. Well, we can now, with modern technology, this is where the world is really exciting in the development of cardiovascular disease or prevention, because it, in essence, and many cardiologists accept now, it's a preventable disease. Yes.
Okay.
So just going back, statins, which reduce cholesterol level, have been promoted as the great prevention of cardiac disease.
Right.
They were introduced almost when I started medicine 35 years ago. I remember the first one, simvastatin, the great excitement of it, and it was shown to markedly reduce cholesterol levels. Yes. And then there've been, studies on hundreds and hundreds of thousands of patients since then. Yes, each one promoting that the statins are good. Yes,
Right.
but this is where the internet, not conspiracies, but the other side of it comes in, because there is some validity in their issues, in their beliefs. Yes,
Okay.
statins are not as dramatically beneficial as we would like to think, or perhaps they are claimed. Yes. So you will hear the claims, oh, statins reduce the risk of heart disease by 50%, 60%. Yes. But, this is where one needs to be careful between what's called relative risk reduction and absolute risk reduction.
Can you explain that a
Yes.
little bit?
So, if you have a disease, your chance of developing of 100 people, say, of suffering a heart attack would be perhaps 0.2. So 1 in 500 people might get a heart attack, say, each in a year. Yes. So that absolute amount is pretty small, because there's 499 people would not have a heart attack.
Yes.
If you then reduce the risk by 50%, well, you've suddenly made it to 1 in 1,000 people would get a heart attack rather than 1 in 500.
Right.
So that's what the relative risk reduction is, but the absolute risk reduction is actually pretty small. And that's what statins do. And one of the biggest studies of statins, about 10, 15 years ago, called the Jupiter study, on almost 20,000 individuals who were chosen to have high cholesterol with no symptoms of heart disease. So this is what we call primary prevention. Asymptomatic people, you're trying to prevent them from developing a heart attack. And the statin significantly reduced the cholesterol levels. Yes, and it was claimed, yes, it was reducing the risk of those individuals' future getting a heart attack by 50, 60%. Yes, the actual reality in the almost 2 years of the study of 20,000 people was something like 0.37 of people who were not taking a statin developed a heart attack, and 0.17 of those on a statin. So
Developed a heart attack.
who suffered a heart attack.
Right.
So the relative risk reduction, yes, was 50, 60%, but the absolute reduction for you as an individual is very small.
Okay. So we will come to the risk factors of coronary heart disease in general, because I know you said cholesterol is just one factor of many. But why do people, at what point does one get a heart attack? What happens in the arteries of the heart so that a person gets a heart attack?
As I suggested, it's this area of furring up bursts. Yes, and it ruptures.
Bursts.
Yes.
Okay.
And so it's when it ruptures and you get a blood clot forming on that irregular surface within the vessel, the artery, then you get a blood clot on it, which then occludes blocks the blood. And then the muscle surrounding that, which is supplied, the heart muscle, which is supplied by that artery, dies.
Is there one form of built-up that is more dangerous than the other, or all built-up in the arteries are the same?
No, we now know that there are two types of furring up. So one, and this is where the technology is becoming so exciting, is most of the areas of furring up get chalk or calcium deposited in them. So within these plaques is an inflammatory process, and within that inflammation you get chalk, calcium lay down. Yes. Those plaques tend to be slightly more robust, like the chalk in your kettle furring up. Yes. There's another type of furring up, which is so-called the soft plaque, which is more pure cholesterol, and that's much more soft and vulnerable. And my analogy of that, it's like one of those old-fashioned Rolo sweets, the toffee
Yes.
sweets. Yes, the lining of that plaque is much softer, and that can burst, allowing all of the soft cholesterol to ooze out and rupture. And
And cause a heart attack.
that's by far probably the most common cause of sudden death, causing a sudden major heart attack.
Okay, so we always say it's 1/3 lifestyle, 1/3 genes, and 1/3 chance. There's nothing we can do about chance, or genetics for that matter, but there's definitely something we can do about the lifestyle. So, risk factors, if we do not want to have built up of plaque in our arteries, what should we do?
It is like for many diseases, it's adopting a healthier lifestyle. So the simplistic ones, if you smoke, stop smoking. Yes, take up regular exercise, reduce the weight. Yes, keep an eye on the blood pressure, and if you have diabetes, control the diabetes. But I think, Ahmed, another really important factor is, sadly, or it is a fact, a third of people who have a heart attack have no risk factors.
No risk factors, as in
No risk factors. They're absolutely slim. Is the weekend warrior, the joggers, healthy, fit males, in their 50s, go out for a jog, have a tragic, massive heart attack.
so how could they have a heart attack if they don't have any plaque built up in their
Oh no,
arteries?
they may well have plaque, but they've got no risk factors for it. So
Oh,
their plaque is a combination of genes or just bad luck.
so someone can be healthy, fit,
Absolutely.
maybe cannot identify direct genetic lineage
Yeah, absolutely.
and still get a heart attack.
Yeah. And until now, we haven't been able to identify that third of people. That's a massive number of people who have no risk factors but who suffer a heart attack. But what we can do now, and this is where the excitement comes in, is that with modern technology and specifically a CT scanner, can look at the coronary arteries, and is exquisitely sensitive CT scanners are for detecting calcium. So I mentioned that the plaques, most of them, the vast majority, have got calcium deposited in them. Well, if you have a CT scan, that will give you a very accurate global assessment of the amount of calcium, and therefore all the studies show that it equates to the amount or proportion of furring up that you have within your heart arteries. And that is the most accurate means of assessing someone's risk of future coronary atherosclerosis and the future risk of developing a heart attack.
Okay, so I haven't been kind to myself over the years,
No,
and I
don't put
think
yourself down.
and I think it is about this time where I potentially go see a doctor, and they might say, well, you might have high cholesterol. This. Here's a prescription of a statin.
Yep.
So I'm a bit of a skeptic. I don't want just to take statin, especially if I know if I take it, I will have to take it probably for the rest of my life. So I need to be able to take the right decision or be educated enough on the subject to take the right decision. So can you tell me what are statins?
Well, look, statins are, drugs which block the synthesis of cholesterol. Most cholesterol is, just going back, of our total amount of cholesterol in the body, most of it is we make ourselves, irrespective of our lifestyle. Yes, and it's
Okay.
made in the liver. And statins block the production of cholesterol or block the enzyme, one of the key enzymes in this. Some cholesterol, yes, is influenced by our diet. So if if you have a diet very high in saturated fats, that will increase your cholesterol, and improving the diet will lower the cholesterol.
Okay, let's talk about that for a moment, because again, the new ideology out there is do not worry about cholesterol. Just eat as much meat as you want. Steak and eggs. There are videos that says, "Hey, I ate 50 eggs this week, and here's what happened." And they live to obviously make the video. So, how much of that is true? Can I really eat as much meat as I want and not worry about it and
No.
all sorts of things? Or,
So, if you're having a lot of saturated fats, and meat, red meat, if it's fatty red meat,
mm,
is high in saturated fats.
right,
Yes, that is going to increase your cholesterol. And as we've discussed, that is one of the risk factors for the development of coronary atherosclerosis.
not
So
the only one,
it's not the only
but
one,
one of many.
yes, of several.
Of
And if you can address that risk, then it would seem sensible if most of us want to reduce our risk of suffering a heart attack.
right.
Yes? And so, if one easier way of doing that is to moderate your diet.
Okay, so back to statins. So they block our body's
Yeah,
ability to produce its own cholesterol.
yeah. And so therefore they lower the amount of circulating cholesterol, and they will slow the rate of progression of any flaring up. But they also, we now know probably around half of their benefits are nothing to do with cholesterol,
Okay,
we call them pleiotropic effects, which are directly on the areas of flaring up and make them tougher and more fibrous and less likely to burst. And that's why they can be particularly good, if you recall, for the soft plaque, which is the most vulnerable type, because they make that lining of the Rolo suite
mm,
tougher and more fibrous.
okay. So the benefit goes beyond just
Yeah,
blocking the production of cholesterol.
yes.
Okay, so is it true that people will go see a doctor, they have a cholesterol of 6.5 or whatever, and they will immediately be prescribed a statin,
Yes and no.
right?
When I started and when the statins came out, if you had the slightest whiff of high cholesterol, you'd put on a statin. Yeah.
Right.
And indeed, some of my colleagues at the time, said, oh, we should give every male over the age of 50, a so-called poly pill. You combine it with statin, aspirin, and a blood pressure medication. Yeah. It's shocking medicine, in my opinion, blunderbuss treatment. You're treating the whole population. So,
Right.
so now the pendulum, as in many things, has slightly swung. Yes, and that they now look at your sort of other risk factors
Mm,
in describing there some statistical algorithms which can determine your sort of 10-year risk. Now, and therefore, if you pass certain threshold, you're then said, oh, you should be on a statin.
right.
But this is population-based statistics. Yes, and as always, it's not necessarily applicable to you as an individual.
Right.
And don't forget, I mentioned a third of people who have a heart attack have no risk factors. So they won't be qualified for a statin. Yes? So you'll have missed them. Yes?
Right.
Conversely, we now know, and one of the factors which would explain this low absolute benefit of statins is that not everybody who meets the threshold for being on a statin
Yeah.
has heart disease. And
Okay.
I did a lot of work of this many years ago. It was when I ran a diagnostic imaging centre and a CT scanner, and we scanned some 3,500 patients who were on statins prescribed by the current guidelines. And we looked at the amount of calcium in the different arteries.
Mm,
And we found that in young people under the age of 55 who are on statins, 40% of men, 60% of women had no calcium whatsoever. No evidence of any heart
and
disease.
yet they were on
Statins
statins.
for life.
Wow.
And then if you looked at the older population, where yes, because as we get older, flaring up occurs more. But even in the older, I'm careful of one's words because I'm now in the elderly time frame, but it was still 14% of men and 30% of women still had zero calcium, but on statins.
So it's a very yes or no kind of black and white deal. If you have calcification of the heart, then you might want to be on statins because of the benefits.
Yeah.
If you do not have calcification, almost regardless of your cholesterol, So if someone's cholesterol is 7.5, 8, but they have zero calcification in their heart, they don't need to have statins.
Well, it is, and that's the exciting thing. I think the CT scan of your coronary arteries for the so-called coronary artery calcium score is a massive advance in determining your individual risk. Because, you've alluded to it also, even the best studies on statins, the compliance rate was awful. About 30–40% of people just didn't take the statins.
Oh, right.
Yeah?
Okay.
And this is in a study where they're being monitored and encouraged to take it. Yes? And many patients still will even take their prescriptions for a statin, cash them in, but just don't take them. They just sit and
Right.
because you said, and it's quite right, this is an asymptomatic disease. So you're taking a medication every day for a disease that doesn't make you feel better, and often you can discuss statins can have side effects. So you need to be, in my opinion, aware why are you taking it. And that's the great advantage of having a so-called coronary artery calcium score. If you've got a high score, absolutely unequivocally, I've got significant heart disease. I am at increased risk of developing a heart attack. I want to reduce that risk. Ergo, I'm going to take the statin. But if you've got a 0 score, then you can be relatively reassured. Now, the one caveat I will have is that coronary artery calcium score only detects calcium. So we mentioned the vulnerable type of plaque, which is the soft plaque. It won't detect that.
What would?
So for that, you need an additional, slightly more advanced type of CT scanner, the so-called CT coronary angiogram.
Right.
And it's as simple, it's a CT scan, yeah, and they just inject a bit of contrast into the vein, yes, and then the actual scan takes seconds. And that will, with the modern high-quality CT scanners, you can see inside the coronary arteries with a resolution of almost as small as 0.3 of a millimeter. So you can now see every little bit of the artery and where, if there is any soft plaque. And that is what has been the game changer, really, in cardiology. The advance of the CT coronary artery calcium score and the CT angiography, because you can now absolutely, with as close to 100% as possible in medicine, which is pretty unusual, tell you do or you don't have coronary atheroma. You do or you don't need treatment.
Okay. And we'll come back to that one, I think, a bit later, because a lot of people would immediately go, oh, CT, my God, radiation exposure, all of that stuff. Fair point. But, okay, so if you have flaring up of the heart arteries, you might want to consider taking a statin because of the advantages. Okay, but what about side effects of statins? Because again, the internet's filled with videos about it will, give you Alzheimer's, it will make you go blind, like all sorts of out there claims about statins, especially with the high dosage. So what are the most common side effects of statins?
Well, look, I mean, any medication can have side effects. That's by definition. If you take anything into you, it can have side effects. And just because you are prescribed a medicine, in my philosophy with patients, doesn't mean you're committed to it, irrespectively. You try it and see. And the side effects are often, we just can't predict whether you are or you aren't going to suffer them. And then you, as a patient, in discussion with your doctor, have to make a valued, informed decision. Do I want to stay on a statin or do I not?
Right.
But the common side effects, around 80% of people tolerate them absolutely fine.
So regardless of the dose?
Yeah.
Okay.
Yeah. So maybe 10–20% of people get side effects, and they vary. It can be just a bit of fatigue. Yes. It can be the most severe cases as muscle aching and muscle damage to the muscles. It's called rhabdomyolysis, where your muscles start to sort of
spasm.
Spasm and get very inflamed.
Okay.
So that's a severe effect. Other effects, it probably does increase your risk of late onset diabetes, statins. So that's a recognized side effect. It can be modified or can be checked by your doctor. There's potential effects on perhaps lowering testosterone level a little bit.
Okay.
But it's really some gut issues.
Is this within the 10 and 20%, or is this for much wider than that?
No, 10 to 20%.
This is just the 10 and 20. But for
those
most
are rare side effects, but they are
recognized.
Yes.
Okay.
my message would be, if you are thought to be at risk of heart disease, and especially if you have objective evidence you've got atheroma, start the statin, see how you get on. And if you really don't tolerate it, certainly the side effects can differ from statin to statin.
Mm.
You know, but
Mm.
and then if you really can't take statins, there are other treatments out there which can also lower cholesterol.
I also heard might be side effects on bone.
It's less certain, and the studies swing. It's probably can cause slight increased risk of bone thinning with higher doses. Yes.
Okay. And then what do you do about that
Well, if you can,
if it develops?
yeah, if it develops and you know you've got developing osteoporosis, then you've got to again make that informed decision. What's your risk of heart disease? Is the statin going to benefit it? What other treatments can you do for the bone? Yes, in women, it would be consider HRT, which can protect against the bone. It's making sure your vitamin D levels are adequate, and or if it's significant, you then start some specific treatment for bone, for osteoporosis.
Right. Okay. So I want to go back to the CT. So you mentioned two things. You mentioned the calcium score and the CT coronary angiogram. I guess one gives you the amount of buildup and one tells you where it is.
In essence, yes. Yeah.
Okay.
The calcium gives you a global score of your overall risk of heart disease.
Mm.
And many studies now involving tens and tens of thousands of patients show this is the most accurate predictor of your risk of heart disease, irrespective of your cholesterol, blood pressure, diabetes, etc.
Okay.
It gives you a very clear risk. And if you have a calcium score, of more than, say, 100, yes, then some studies show that's associated with a 40-fold increased risk of a heart attack. So it's
Wow.
a powerful tool,
Mm.
yes. But it won't tell you exactly where the degree of furring up is. It won't tell you the degree of narrowing of the artery, and it will unfortunately miss the soft plaque.
Right.
So for that, it's the CT coronary angiogram, which is a slightly more complicated study.
And are these two different tests or in the same machine?
Usually, it's the same machine. Usually, you'd have a calcium score, which is quick. But then if you want to proceed, then they put the needle in, inject dye, and you proceed to an angiogram, CT
Okay.
angiogram.
So that sounds terrifying because CT radiation, and then you're going to inject something else as well.
Yeah.
What would you say to that? I mean, there's always a concern with CT radiation.
No.
How much of a valid concern is it?
Look, it is a concern. It is a theoretical concern. Yes. Firstly, the modern scanners emit and deliver much less radiation than they used to.
Right.
When I started and was involved with diagnostic imaging, and we still had one of the most advanced in the country, compared to now, that now there's about a 10-fold reduction in the radiation.
Okay.
So a CT angiogram for a relatively slim person, yes, is probably the dose of radiation is probably equivalent to you visiting Cornwall for a few weeks.
Why Cornwall?
Because Cornwall has a very high background degree of radiation in the granite, in the radon, in the granite rocks.
It's the same amount of exposure.
Yeah, so there's a high background level of radiation in Cornwall. Yes, so if you visit there for a few weeks, you get the same dose probably as a modern CT angiogram.
And there's no statistics that says people in Cornwall have higher risk of cancer versus other areas in the country.
Not at all.
Okay.
So but having said that, you don't want to be irradiating someone, nor would you be allowed to, because there are very strict rules as to who you can irradiate. Yes, so you wouldn't be doing it monthly. If you have a CT heart scan or angiogram, yes, you probably don't need it doing for at least 2, 3, or even 4 years, depending on the findings. So it's an occasional scan.
Right. Okay. We also spoke with a cardiologist, Dr. Azad, who's fantastic. And we asked him some tough questions. So let's go to the interview and maybe come back and have some final thoughts.
Yeah, absolutely.
Let's hear what you had to say.
So we're delighted to have with us today to join us Dr. Azad Ghuran, who is consultant cardiologist at the Lister Hospital in Hertfordshire and a specialist in coronary heart disease and renowned expert in interventional procedures. So Azad, welcome to the Wealth of Health podcast.
Thank you very much.
So I'd like to, just start perhaps with a slightly not necessarily controversial question, but perhaps, is it that cardiology now, or coronary heart disease, is largely a more preventable disease?
Well, yes, coronary heart disease or cardiovascular disease is the leading cause of death worldwide, both in developing countries and in developed countries. And despite tremendous, improvement over the years in treating coronary heart disease, it still remains a number one killer. And I think the treatment or the screening for cardiovascular disease is changing. Now we have the technology to use it to our advantage for precision medicine.
And with the technology, I mean, suppose, what is the technology you're referring to?
Well, cardiac CT scanning.
Okay.
Now, over the years, cardiac CT scanning has evolved. In the past, I would have said the radiation dose was quite high, and it was a niche tool mainly for research. But we have a wealth of data now that has demonstrated that cardiac screening using CT to pick up not only coronary calcification, but the actual disease itself, which is atherosclerosis. And again, risk scores try to predict atherosclerosis. With cardiac CT, we're not predicting, we are identifying the disease process, which is atherosclerosis. So cardiac CT scanning will pick up the disease process, atherosclerosis. So you're not trying to predict it. And we know that these prediction tools, these risk factors, they are imprecise at an individual level. So I've seen over the years many patients with, be it renal failure, which is the highest risk population on hemodialysis, patients with diabetes, patients with very high cholesterols of over 8, they have normal coronary arteries, completely normal coronary arteries. Whereas you have patients with, the lowest I've seen was last week or 2 weeks ago. In fact, it's one of your patient, his cholesterol was 3.2 with an LDL below 2. And he had a 50% non-calcified plaque in his proximal left anterior descending artery.
Okay. And when you say cardiac CT, are you looking at the calcium score or the CT angiogram? And following on from that, can you tell me and our listeners the importance of the soft plaque that you say you identified? Why is that so critical to determine?
Now, soft plaque, it means that in the development process, there's a roof over that plaque. And if that roof fractures or breaks, you get a clot forming on top of that plaque and it completely blocks the artery. And that was causes, as mentioned before, a heart attack or stroke. And so soft plaque is very important to identify. Now, once we identify it, what can we do about it? Well, we try to initiate preventative therapy. And the main, at present, preventative therapy is largely by using statins. And what statins do, it's not about just getting your cholesterol low. There's a lot of data, that show that statins at moderate or high doses can cause plaque regression, trying to avoid plaque progression. But more importantly, it could stabilize soft plaque. And by stabilizing soft plaque, you're getting calcium entry into the plaque to stabilize it. Statins, independent of cholesterol, so whether your cholesterol is high or low, independent of it, statins have plaque stabilization effects by strengthening that roof. So that's one. So it strengthens the roof. And by strengthening it, you get calcification. It's like calcium buildup in your kettle or in your pipes. When you get calcium, it's very hard. So you get calcification. 2, inflammation. Statins have anti-inflammatory properties. So just like how fruits and vegetables have anti-inflammatory properties, statins have anti-inflammatory properties. So conditions such as rheumatoid arthritis, lupus, after an infection, these are risk factors for heart attacks or patients with soft plaques. Statins have anti-inflammatory properties. Statins also have anti-thrombotic properties. So thrombosis is the process where blood clot forms. Statins have anti-thrombotic properties. So there's a number of reasons, regardless of cholesterol level, regardless of trying to lower cholesterol level, why statins are beneficial in patients with heart disease.
Fantastic. So my role in this podcast, if you will, is to bring in what the public are talking about, or what is the alternative view maybe that's prevailing online. And there is a very big drive, even from some clinicians, I would say, on YouTube or on Spotify, to promote what is known as the carnivore diet. And that's practically just really just based on saturated fat, you know. And there's just that loose, oh, go out and have 100 eggs a week and eat steak every meal and don't worry about it because A, cholesterol is not that much of a risk factor when it comes to coronary heart disease. And B, you also don't need statins. So I like your reflection a little bit, primarily on this diet, on high saturated fat diet. What really is the impact of high saturated diet on someone's health? And what's the correlation then, again, with cholesterol and the good cholesterol and the bad cholesterol? Because also a lot of people don't really know the difference.
Okay, so when you're dealing with cholesterol, you have total cholesterol. That's what everybody talks about, total cholesterol. And total cholesterol is divided into good cholesterol, which is HDL cholesterol. It's divided into bad cholesterol, which is LDL cholesterol. But you also have other subfractions called VLDL cholesterol and IDL cholesterol and triglycerides. And when you summate all that, you'll get your total cholesterol level. And that's what everyone looks at. Now, the bad cholesterol circulates around the body, and that's LDL together with VLDL and IDL, which we don't tend to measure or talk about in clinic. And that can be deposited into walls of the artery. HDL is a good cholesterol, and that goes around, takes the bad cholesterol from circulation, takes it back to the liver to get rid of. So you want a high good cholesterol. However, one has to be cautious. It's not as simple as that, because although your HDL level might be high, and some patients it could be over 2.3 or much higher, it could be dysfunctional. In other words, it's high, but it's not doing the job to take the bad cholesterol from circulation. So you might be falsely reassured that, oh, my cholesterol is high, my good cholesterol is high, therefore I don't have to worry about my cholesterol. Wrong. And the clue is usually in family history. You have patients with very high, and there's data to show that when your HDL cholesterol is 2.3, the benefits of HDL is, it becomes a risk marker. And therefore, you have to interrogate the family history. And if there's a family history, then you do have to wonder, is that HDL cholesterol dysfunctional? Now, the high protein diet, or rather the high saturated fat diet, I personally completely disagree with this. And because we do know that high concentrates of saturated fats has been implicated, and there are a number of studies that have shown that it's associated with a much higher cholesterol level, which is implicated in cardiovascular disease. So an overindulgence in saturated fats is unhealthy in my opinion. The other thing is eggs. Eggs has been controversial over the years. Does it cause cardiovascular disease? And yes, it can elevate cholesterol. It's about 200 milligrams of cholesterol in an egg, roughly, approximately. And there's other components in eggs, or even in meat. And there was an article published in the European Heart Journal a couple of years ago. And it's not about only cholesterol. There's a compound called trimethylamine N oxide, or TMNO. And that itself is also has a strong risk marker for cardiovascular disease or atherosclerosis. And that's found in eggs as well as meat. So so overconsumption is like anything else. I mean, I like eggs, so I eat eggs occasionally, but I don't take huge amounts of eggs every day. Like everything else, too much is not good for you. Too little might be, okay, not good for you, but having it in moderation.
In summary of that one, we just say, therefore, that like most things in life, moderation is best in terms of your lifestyle. Avoid extremes. Yep.
Yes.
And to try and the earlier, so also coming back, I guess, to where I started, you're saying that largely cardiovascular disease is preventable if you get it early enough, the effective steps you can take to prevent it from worsening and stopping you getting up in the middle of the night to treat a heart attack. And when you say to treat it, times have changed since I was a junior doctor, when we basically used to lob you an aspirin and tell you to get on with it. Yes. Nowadays, your treating a heart attack is interventional cardiology and putting a stent in or angioplasty and disrupting the clot that is formed on one of these burst plaques.
That's absolutely correct. Yes.
Yeah.
Well, thank you very much, Dr. Ghuran. It's been fantastic, and thank you for all the advice and the explanation you provided. I'm sure a lot of people will get huge benefits from listening to your opinion and your take on things today. So thank you very much. It's been a pleasure having you, and I'm sure we will speak to you again soon.
Well, thank you very much. I quite enjoyed it, and I'm a strong advocate in prevention. Thank you.
Thank you, Azad. Well, that was fascinating.
I
A
know.
bit of insight from Azad, a very experienced practicing clinical cardiologist.
Yes. Yes.
So I think you've heard my views, background. You've heard Azad's view. Yes. You started the podcast slightly on the skeptical side. Yeah?
True.
Do you think, have you changed your mind? If you were told, you should, by your GP, you should start a statin, would you now or not?
Well, I think I feel like I'm more empowered to make the right decision. Well, I think I would ask them first, well, what is my calcium score? I need to see if there's furring up of my heart arteries or not. Because if there's no furring up, no, I won't take them.
Well,
But how likely is it that I will be referred to a CT?
well, that is, Ahmed, that's one of the issues. Yes, what we've spoken about is the gold standard.
Right.
And that's what I'm always interested in, is what's actually best for you as an individual. Yes, but we are largely hampered or constrained by the NHS and its sort of limited resources or finite resources, and the resources and the availability of CT scanners in the NHS. So I think if you are asymptomatic, the chances of you having a coronary artery calcium score scan is really not going to happen.
So I have to do it
NHS.
privately.
So you've got to go privately.
I have to go privately. Yeah. Or if people are watching from anywhere else in the world, they probably can go.
It's possible. Different
it.
health systems. So in the UK, the next question is, what's the cost of it? Probably a calcium score is around 500, give or take 100. And then a CT angiogram, because don't forget the calcium score, if you want the absolute gold standards, is the CT coronary angiogram.
Yes.
If you're over the age of 40,
it's the one that tells you about the soft plaque, which
gives you close to 100% knowledge.
Okay.
And that's probably in total about £1,200 to £1,500.
Okay.
There's no doubt it's a lot of money, but if this is your chance of assessing you, definitively, and you only need it perhaps once every 3-4 years,
I think if it means I have the right information to make a decision about a medication that I'm going to take for the rest of my life, I'll probably ask that question, at least demand it, and then I would consider my other risk factors. If I have diabetes, if have insulin resistance, my BMI, or my weight, my height, how many times I exercise in a week, all of that. You just have to be honest with myself.
But those would all help your general well-being.
True.
Yes. The CT angiogram is it, and irrespective of your risk factors, it will clarify it. I have it myself. I have a CT angiogram, and more doctors do. They recognise the benefits.
I think the key here is high cholesterol on its own is not necessarily a sentence of coronary heart disease.
Yeah. And ideally, I suppose the end point is, ideally, you should try and get individual assessment and objective data on the state of your coronary arteries.
And that's the common sense middle bit that we were.
So we come back to where we started.
That we were talking about, I think.
Well, I think that's probably summed it up.
Yeah.
And that's I think we've got all we've got time for today. So thank you for listening and watching, and until the next one. Goodbye.